Hello everyone, today we'll be talking about altered mental status and how to work up a differential diagnosis. Again, in this lecture should give you a fair idea about how to start thinking about altered mental status, but there's certainly a lot of things that you can build upon. Please review my previous videos on this topic. As we have talked about in our previous lecture, that any injury or dysfunction to your reticular activating system which resides in brainstem, thalamus or bilateral cortices can result in altered mental status. The cortical dysfunction has to be diffuse and bilateral to result in altered mental status. To understand what is the underlying cause, let's examine what can cause these symptoms. There are 5 main reasons for altered mental status. You have drugs and ingestion, organ failures, infection, seizures, and structural brain lesions. The first 4 causes result in diffuse cortical dysfunction by various means. For a structural brain lesion, you either need an injury or dysfunction in your brainstem or thalamus, or diffuse injury to your bilateral cortices. Remember that there may be more than one etiology at play in causing mental status change. An easy way to remember these 5 is acronym BIOS, that is brain, ingestion, organ failures, sepsis, and seizures. First step is to rule out trauma. Signs of trauma include bruising in extremities, trunk or back. Look for ecchymosis around eyes and mastoids. Examine the eardrum for hemotympanum. Look for nosebleeds for halo sign, which can suggest CSF rhinorrhea. Most of these patients would have their routine labs drawn and CT brain or CT trauma ordered in the ER. CT scan is very important in evaluation of altered mental status. So it's important to understand some basic findings. Blood appears white on the CT scan and cerebral edema appears darker than surrounding brain. Cerebral edema will result in loss of sulci and loss of gray-white zone differentiation. Look for ventricle size and symmetry and look at midline shifts. Next, look for signs of drug overdose and ingestion, and here the history is the key part of the evaluation. Always get history or look at the EMS record and try to figure out clues towards ingestion. If you find a family member, ask about drug abuse, history of drug overdose, any psych history, suicidal ideations, any new changes in medication, and always perform medicine reconciliation. On exam, look at vital signs and examine pupils closely. We'll talk about these toxidromes in another lecture. If you're suspecting ingestion, check for alcohol levels of Tylenol and aspirin, urine drug screen, and serum osmolality. Remember that many drugs would not show up on the toxicology screen, and heavy metals usually cause subacute presentation. There are so many other drugs that can cause mental status, so history is the utmost importance, and always make sure that you perform a good medicine reconciliation. Next, look for signs of infection. Sepsis is mostly subacute in presentation and progresses over a few days. Elderly and debilitated patient may not have fever or leukocytosis, and here you are looking for brain infections such as encephalitis. Meningitis usually doesn't cause altered mental status unless it is associated with encephalitis. Sepsis in elderly and debilitated and patients with chronic organ failures can result in altered mental status. UTI is a very common cause of altered mental status in elderly. Clues for infection include things like fevers and chills. Look for specific signs of organ symptoms like headaches, cough, burning micturition, abdominal pain, etc. Examine the skin for rashes and see if the patient is in vasodilatory shock. On labs, look for white cell count, but also pay attention to bandemia and toxic granulation, which can suggest infection. Check your chest x-ray and urine analysis, and if needed, perform lumbar puncture if CNS infection is suspected. Start your empiric antibiotics as per your suspicion. Next, look for organ dysfunction, and here we are talking about 4 major organs: liver failure, renal failure, respiratory failure, and cardiac failure. Patients with hepatic failure will have elevated ammonia, which can cause cerebral edema and can cause altered mental status. Respiratory failure patients can have hypercapnia, which suppresses your respiratory center, and hypoxemia, which can cause global neuronal dysfunction. Similarly, patients who are hypotensive will have global ischemia, resulting in alternate mental status. Just because these patients have normal oxygenation and normal blood pressure in the ER does not mean that they were same at the time of presentation. So find out if they were hypoxemic or hypotensive at any point of time, as these patients may have developed anoxic brain injury during the period they were hypoxic or hypotensive. Lactic acid is not always from sepsis or hypoperfusion. It can be seen in multiple other conditions such as diabetic ketoacidosis, Wernicke's encephalopathy, cyanide and carbon monoxide poisoning, Tylenol poisoning, and many other volatile drugs. Similarly, ammonia elevation is not always from liver disease and can be seen in other conditions as well. Next, look for signs of endocrine dysfunction, and of this, most important is your blood glucose level. Understand that hypoglycemia can occur in other conditions as well, and not only in diabetics. Patients who are elderly, alcoholics, in liver and renal failure, and chronically malnourished can have hypoglycemia. Sepsis is another cause of hypoglycemia. Adrenal insufficiency and thyroid insufficiency can result in altered mental status, though presentation will be subacute. Next, look for electrolyte and nutritional issues. Electrolyte abnormalities can be simply found by looking at your blood chemistry profile or EBG with electrolytes. And here you are looking for hypo or hypernatremia, hypercalcemia, or very low pH. Monitor their temperature, as patients with hypothermia or hypothermia can be altered. Look for signs of hyperglycemia and hyperosmolarity. Patients with thiamine deficiency can be seen in malnourished alcoholics, history of bariatric surgery, cancer patient, and hyperemesis gravidarum. Next, look for primary brain issues. The reason for altered mental status is reticular activating system dysfunction, thalamic lesion, or global cortical problems. So these are few differential for primary brain issues that can cause mental status changes. CT brain is usually available by the time you are seeing this patient. CT is really good at finding bleeds such as subdural hematoma, subarachnoid hemorrhage, intracranial hemorrhage including thalamic and brainstem bleed, hydrocephalus, cerebral edema, and massive strokes. If you suspect other etiologies, go ahead and perform CT angiogram with perfusion, MRI, EZ, or lumbar puncture as per your suspicion. One of the most important things to understand is negative CT brain doesn't mean that your brain is normal. CT brain is pretty good at finding bleeds, brain shifts, edema, and hydrocephalus. However, it is very poor at figuring out acute strokes, especially early in presentation. It can also miss a small embolic stroke, evaluating posterior fossa lesions, cerebral venous sinus thrombosis, press, and meningeal inflammation. So depending on your history and exam findings, you can order other tests to confirm your suspicion. If your patient had seizure and is not waking up, either these patients are in post-ictal state or have non-convulsive seizures or non-convulsive status epilepticus. In one study, patients who did not awaken after convulsive seizure, continuous EEG detected 48% non-convulsive seizure, and of which 14 had non-convulsive status epilepticus. Rate of non-convulsive status epilepticus is around 20% in high-grade subarachnoid, intracranial hemorrhage, and traumatic brain injury. Signs of non-convulsive seizure are very subtle or usually absent, but you can look for things like exaggerated hippus, gaze deviation, spontaneous nystagmus, abnormal posturing, bruxism, or unexplained tachycardia or tachypnea. If you think that patient has non-convulsive seizure, order a continuous EEG. Now you know the different etiologies for patient with altered mental status. Let's try to put them together. Initial care of comatose patient include your airway, breathing, and circulation. That goes for all the sick patients. Monitor their blood pressure, EKG, pulse ox, and get an IV access as soon as you can. Evaluate for signs of trauma and stabilize your C-spine. If you think patient need intubation, go ahead and intubate them. However, understand that GCS less than 8 is not always an indication. Think about underlying etiology and expected clinical course before making that decision. Avoid non-invasive mechanical ventilation in your comatose patients. Always get blood glucose levels. EBG is very useful and can give you a lot of information much more faster than a routine lab or a stat lab. It can give you idea about hypercapnia, hypoxemia, acidosis, electrolytes, and can also give level of carbamino and methemoglobin levels. If you're thinking about Wernicke's encephalopathy, give them thiamine. If you're thinking about opiate overdose, give them naloxone, but don't use them routinely on all patients. Next, perform a quick history and exam, rule out trauma, check CT of the brain, and see if your patient needs additional exam. A negative CT does not mean your brain is normal. As per the indication, perform CT angio, lumbar puncture, EEG or MRI. Look for ingestions, check osmolar gap, drug levels, do a thorough medicine reconciliation and get more history. Look for signs of sepsis, start antibiotics early, look for organ failures, and look for endocrinopathies. Whenever you approach patient with altered mental status or coma, follow same exam algorithm for each patient, and in time you will get more efficient. Usually we order the panel, but always take a moment to think. Don't get lost in the data and understand that negative CT brain doesn't rule out many etiologies. Be cognizant of the fact that there can be 2 or more processes going on which are causing your patient to be altered. Thank you.